and I'm very pleased to be the moderator for this webinar, ProviderPayer Alliance for the New Normal of Healthcare. So with that, let's get started. I'd like to introduce our panelists. First, my good friend, longtime colleague, David Nash, founding Dean Emeritus at Jefferson College of Population Health. David, welcome.
Thank you. Good afternoon.
I'd also like to welcome my esteemed colleague, Patrick Conway, currently the CEO of Care Solutions at Optum. And many of you know him as former president and CEO for Blue Cross of North Carolina and CMS, where he was the deputy administrator and director at the Center for Medicaid and Medicare Innovation. Patrick, welcome.
Great to be here. Thanks for having me.
Awesome. So this is going to be a great discussion. You know, we're in the middle of COVID and a lot going forward. Just for the audience, as you're getting assembled, please use the question and chat function in your GoToWebinar panel. You can submit questions as we go along, and I'll try to track those. And when appropriate, bring them in. Otherwise, we'll bring a few questions forward at the end. So let's get into this. So we have a new normal currently. It's kind of a COVID normal, maybe a middle normal. Patients have a lot of questions, more questions than they've ever had before. David, what are providers experiencing in terms of patients' questions?
Well, first of all, I want to say thanks to Patrick Conway for joining us. Great to see him, and David Nace. Great to be together. Let's not confuse Nash and Nace. And here we are in the middle of August. Who would have thought it? I'm actually broadcasting today from my office in Center City, Philadelphia. This is the second time in 5 months that I have been sitting in our office. I am the only person on the entire floor of our building in downtown Philadelphia. So David, I'm going to pick on you already. New normal. Why do we even call it that? There is no new normal. There's just what it's going to be like. I don't think it's ever going to be normal again. And my sitting here by myself in our building is a testimony to why do we call it the new normal. So look, I'm really thrilled to be celebrating my 30th anniversary at Jefferson, and our amazing leader, Steve Klasko, who's now going on year 7 with us. Of course, you appreciate we were 5 years ahead of the rest of the world by building a telehealth, telemedicine capability literally 5 years ago. And everybody said to Stephen, why are you putting resources in that? We recruited 8 full-time faculty members from a small Ivy League university in West Philadelphia to come and join us here at Jefferson. And they've become national leaders in delivering what I'll call digital health. So people loved it. I think the new activity as it relates to delivering these services, it's all consumer-driven behavior. It's largely frictionless, no danger, no waiting in an office with strangers, no driving to an abandoned building in Center City like the one I'm sitting in. So why not? I mean, I think it's we're catching up with the banking industry. That's kind of our party line on what you're describing as the new norm. Now, there's lots more to it in terms of the untold burden, who we really needed to see, who is still not coming to the doctor. But I think to answer your question, why now more than ever, it's frictionless, it's easy, it's straightforward, it's not expensive. And it's like, since we've been doing everything else online for the last 4 months, why not healthcare?
No, that makes sense and great perspective. Patrick, you've been on the payer side, both government and Blues plans, now Optum. What's your perspective for your members in terms of kind of questions?
Yeah, I'll start from my days at CMS. It's interesting to watch this progress. We tried to do a lot of work to expand telehealth and virtual care when I was there. Quite honestly, ended up having to do it through Innovation Center waivers, which were good in that you had these providers and these new models that could use telehealth and have waivers. But I always had an angst, if you will, that it applied more broadly, and why couldn't we make the change more broadly? Fast forward to the current events where I think the administration's done, honestly, a terrific job opening up flexibilities in telehealth and virtual care. So I think including some recent announcements, which I think we may talk about, to make some of these changes more permanent. So I think the push from public players on telehealth virtual care is right on. And then, Blue Cross North Carolina and now United and Optum as well, we are trying to maximize how we provide care via telehealth, virtual care, platforms. How do we really open up care to patients, to people, to families, when and where and how they need it, and use technology to do that. So, I agree with David, and you're right. We'll have the Nace and Nash. We'll have to figure out I'll start calling you by your last names or something. But I think it's now the normal. It's I think we're not going to reset to the baseline we were at, and I think that's exciting. It's going to push us to deliver care in new ways.
It is exciting, and it sounds like there's a silver lining behind all this. It kind of is moving us forward. Now, there's a lot of questions, though, about the telehealth and to some degree virtual care. Is it just for acute care? How is it with chronic care, people that have multiple comorbidities? And then, David, you brought up the importance of social determinants of health. So how do you think this will play out in terms of how this can help us move forward?
Yeah, wow, great couple of questions. Let's see if I could sort of unpack it. So first, there's some new literature, JAMA, and in our journal, Pop Health Management, from Jaffe and her team. The availability of these services is not uniform. That's putting it very nicely. I mean, we know that in the minority community, and especially in urban communities of color that may not even have access to telehealth services, it's a really important issue. We saw it in Center City, Philadelphia, with our minority patients not having the same level of access as our suburban patients. And I think in the elderly, especially the frail elderly who don't know how to use these tools. So we can't first assume that this is uniform access to this fantastic technology. The second thing is, I brought with me some material. So this is the August 2020 report from ARC that says, wow, telehealth, fantastic, but let's not forget that there's so little research still on making the right diagnosis. There's very little outcome measures. I mean, outside of a handful of major national firms who report that they're looking at their outcomes, David Nace, you and I know there are very little measures that this is actually achieving the health outcome that we all want. I hate to be the naysayer, but in God we trust. Everybody else bring their outcomes data. That applies to telehealth, I think, as well. And we just don't have the data. So those pesky social determinants are still very much active. The lack of outcome measures is still really, really important. And I think, it makes a great story. And of course, the recent merger of Teladoc and Livongo got everybody's attention because it's the sort of the first big deal in this arena. I'm all for it, but I also would like to see more research and more measures.
So Patrick, you've got this new group, Care Solutions, and it really starts to drive much of the care continuum together. How are you thinking about the use of these technologies and some of the reservations that David just brought up?
Yeah, so we're, what we're doing at Optum with Care Solutions, it's really how do you provide care across the continuum from hospital to post-acute to home, including mental and behavioral health care delivery, and agree with David, addressing social needs. I'd say a few high-level points. One is I'd encourage us to put telehealth and virtual care in a broader system that's still value-based and population health management-based. Rahul Rajkumar, who I worked with in North Carolina and in the Innovation Center, just wrote about this. If we just recreate a fee-for-service system, I think it's very unlikely to deliver the value we want. It won't. So how do you put it in a context of value-based care and population health management? I think that's what we are trying to do at Optum to drive better care for patients. The second thing that David said, it's funny, I actually said this to a philanthropy 2 days ago in this space on the research aim. I'm really worried about health equity issues, both the outcome measures broadly, and then as you move to this new care paradigm, could some areas of health equity actually get worse? So how do we not only measure that, but address that and think about how you use a new paradigm of care delivery to actually address health equity as opposed to potentially have unintended negative effects. So I think that's a real issue. We're excited about this. We think there's a huge opportunity to deliver care into the home and into settings where people want that care. But I agree with David. We need to measure that care. We need to think about it in a population way, better health, better experience, lower costs, and continue to iterate and learn as we deploy these new technologies and services.
Hey, David Nace, one thing I would add to Patrick's really nice answer, maybe as the marginal cost of these technologies decrease, that will enable us to reach further and further into communities who we have largely ignored. So let's hope that's the case. Of course, at the moment, really, we don't have that evidence yet, but I'm hopeful as the unit costs go down, marginal cost decreases, we overcome the fixed costs of the technology, we might be able to reach communities who typically we haven't really cared that much about.
So this is great, capturing these comments. And, it sounds like we have a great opportunity to have this be a silver lining behind COVID, moving forward with these technologies, learning about them. But there's a lot of uncertainty about how this will play out, right? Will there be a resurgence? How do I revert to managing non-COVID-19 care when your building is full, David, not just
Correct.
people in the home? So
Yes, this is fascinating. So look, I can't speak for all providers, for sure not. But across the street from where I'm sitting, actually that direction, the clinical building is full. And in July, we actually beat budget expectations as they compared to July of 2019. So I can't take credit for any of this, but the Jefferson faculty are working, in overdrive and are exceeding their visits in person as compared to budget and as compared to projections based on June of 2019. So are patients coming back? I think so. And that's in part because we have focused on safety, 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 and safety. And it's in our day-to-day. It's all part of our DNA now of keeping the staff safe first and then the patients. So we've made a lot of progress on the culture of safety in the ambulatory setting. And I think in part that's responsible for bringing back a large number of our patients. But again, David, you and Patrick are both so sophisticated, we have no data on what really happened in March, April, and May, because we didn't see people for chronic disease. What's the true untold burden? Sure, I understand that probably we had MIs and strokes at home, no question. But on the preventive side, the chronic disease management side, the cancer prevention, we're just now understanding the size and the scope of the untold burden. But as of today, August, sitting here, the building across the street, totally busy with outpatient visits.
Well, to your point, David, you can't speak to what other providers are experiencing. So let's do a quick poll, and then I have a question for Patrick. What is the impact of the pandemic on your organization? Just go onto the chat box and answer these questions. We're still in the middle of it. We're in a state of performance improvement experimentation. We're barely holding on. We're adjusting our operations for a new future. We've made some changes, but we expect everything to revert back to the standard fee-for-service environment where we really weren't impacted and operations haven't changed. So Patrick, you and I've known each other. I remember you going through the time you were at CMS, and you've always had the same philosophy. How will we think about not reverting to high profit service line delivery in a fee-for-service? And how will payers,
Yeah, let me, first from I'm naturally optimistic, and then I'll share something that I saw today that gave me pause. I don't think we'll revert back, so it'll be interesting to see what the poll says. But I think from a payer perspective, both public and private, this is the direction we're going. I worked in Democratic and Republican administrations on the public sector side. The names changed slightly from value-driven healthcare to value-based healthcare and delivery system reform, but it was all, triple, quadruple aim. How do we drive change in the system? That's true in private payers. So I think we will drive for that sort of better health outcomes, better experience, lower costs. I think the move to telehealth, virtual, and in-home care will continue. You know, on the hospital side, and look, I still practice as a hospital medicine physician, but I saw again today a merger of two big hospital systems. And, you know, I was quoted in North Carolina for a merger that didn't go through. I said, I'm not aware of two large hospital systems in the history of U.S. healthcare that have merged and costs went down for consumers.
Right. Never
Once
has
again,
happened. Right.
You know, prove me wrong, but I'm not aware of that ever happening. Yeah, David agrees with me. And so,
not only that,
and it made those.
Right.
Yeah.
And there's no evidence that quality has gone. Yeah. So I can't resist. And there's no evidence that quality's improved with all of those mergers either.
Exactly. And so I saw this announcement from a CEO that I knew, and I almost texted him, but I didn't. I mean, it's like, you got to be kidding me. Like, the announcement was all, you know, now we're bigger, it'll all be better, quality will be better, costs will go down. And I'm highly skeptical. The evidence doesn't prove it out, as David just said. And so, you know, I do hope we, you know, if I was a hospital CEO right now, and I'm actually talking to Steve Klasko tomorrow, who's terrific. So, you know, I love Steve. I think he's driven a lot of positive change. But if I was a different hospital CEO, maybe the one doing that merger, I just think we have to think differently. It's not about more beds anymore. It's not about fee-for-service rates like this. That we cannot live in that environment anymore. So I hope hospital leadership realizes and will continue to push, you know, with all of us, that it's got to be less infrastructure, more outpatient care, more care, you know, when and where and how the patient needs it.
That's a great philosophy, and I love the optimism I am hearing with the concerns as well. Let's go ahead and check in with our audience and see what they think is going on. What has their experience been? Let's pull up the poll results. Interesting. What do you guys think about this?
Well, there's that new normal again.
Yeah.
Sure, it makes sense. The majority are kind of, you know, figuring it out.
And everybody.
Yeah, and I was just gonna say, I'm glad to see there's only 16% that are sort of planning to go back, haven't changed or planning to go back to normal. That's heartening.
It's very heartening. So, you know, we've had all this change with the pandemic, the adoption of new technologies, great opportunity moving forward, as we just discussed. But simultaneous to this, something else has happened. It actually happened March 9th, at the same time as the pandemic really hitting for many of us. And that's the CMS and ONC rules for interoperability requirements. So let's talk a little bit about this, because a lot of people have had, I would say, their head in the sand about this. We've talked about interoperability, ubiquitous data sharing for, I don't know, Patrick, David, 20 years. And there's always been efforts made at it. You know, obviously with the High-Tech Act, we thought digitalization would solve it. With the EMRs, it hasn't. But as of now, you know, we have a final rule following the 21st Century Cures Act, which is impacting providers, meaning that, and the timeline has been delayed for compliance to July 1st of next year, originally it was January 1st. But providers are going to be responsible for sending admission, discharge, and transfer information in real time to other providers. As well as CMS is going to provide oversight and publicly report providers around their condition of participation, any information blocking. And they're not going to take excuses, oh, it's my EMR that's blocking, or it's my lab system. They're going to be responsible. And for payers, the impact is gigantic. Payers are now going to be responsible, as of July next year, to have access to patients through an advanced programming interface to any smartphone application or computer application of their choosing, to have access to all their data, including costs, and to have a real-time updated provider directory available, again, to an application of their choosing. And we're moving into a smartphone world. And on top of all that, they have to make available their API, payers have to make available, so that developers from these application companies like Innovator to be able to go in and have information and be able to start developing their own applications based on that API. So a little word about us, Innovation Accelerator, we originally were set as a data platform with the idea that people would come on and build their own apps. The world wasn't ready to that. The world needs to be ready for it. So this is really exciting stuff. I want to just move into a summary of what I just said, implications for providers, implications for payers, and what it means for the patient. But our experience is a lot of people aren't paying attention to this. David, what's been your experience?
Yeah, wow. I'm floored by this, David Nace. March 16th is when we closed our doors here, so no one was paying attention. This got in, below the proverbial radar screen. That's my first observation. My second is this is a huge, heavy lift for most folks in practice. How are they ever going to do this? And it's 11 months away. So we're just getting patients back to visit. How are we ever going to tackle this? So this is a gigantic challenge. I think for systems, with the kinds of resources, people, staff, and all the rest, maybe less of a heavy lift. But for most docs in small practices, this is going to be a big challenge.
Patrick?
Yeah, so I agree with the heavy lift, the sort of operational challenges that, people probably are not fully aware. I often try to go back to principles, and, I still get asked questions from people from CMS and elsewhere. Actually, after my first tour in government as a White House fellow, I wrote an article about one of government's roles is open data, sort of creating data access, and that data is a strategic utility to be used. I still think that principle's on target. I think that's the principle that Administrator Verma and others were trying to probably go for here. Things like the ADT feed I worked on when I was at CMS and honestly struggled to maximize access. I think they're putting it in a construct that will maximize access on an ADT feed. I think the patient access to data, they continue to push. We started Blue Button. They've sort of pushed that much further, which I think is good. I think the APIs and access there was started in the Obama administration, actually started some in the Levitt and with Levitt, and then into Obama with Secretary Sebelius and Secretary Burwell, and now I think Seema Verma and Secretary Azar continue to push. So I think these are natural positive progressions in terms of data access. I also agree with David that the details matter, how you operationalize it matter. So I think the healthcare ecosystem, both payers and providers, it's going to be a heavy lift.
No, absolutely. And David, now that you've kind of become a little bit more familiar with this and attention's off COVID and you're back to work day 2, as you think about this, what does this mean for patients?
What does it mean for patients? Mm-hmm. Yeah. Well, I think from a patient perspective, it's largely positive. Look, I've always thought for the last decade in population health, you can't improve the health of the population unless they're engaged in the improvement process with you. The old prescriptive way, do what we tell you and you're going to get better. That didn't work. So if this gets us on the road to improve patient engagement, recognizing not every patient is going to do this, as we discussed earlier, I'm all for it. Yeah. So for me, patient engagement equals improvement in health. And if this gets us on that road a little further, fantastic. Recognizing the road is not flat and without potholes.
Patrick, I think you were going to make a comment.
No, I was just smiling on the. I agree. I once had someone tell me, we've dramatically improved all these patient outcomes, and I was like, based on the intervention, I'm like, do they know? And they're like, no, they don't know.
Yeah, is that great? That's right. They're the last ones to know. I think
we could probably do better if they were aware of what we were doing to improve their health. So that was where the smile was coming from. I agree. I think, and we've struggled with this, honestly. I've struggled with it too. So, it's a hard issue, but the goal is right on. How do we deeply engage patients, families, individuals, and communities, by the way, in population health improvement. And to do that, I think data and the other tools around the data and information are critical. So certainly from the private payer and Optum, a huge provider of care, we are very focused on how we get people the information they need to drive better health outcomes for themselves and their families.
Now, and I love the comment about the importance of the data. So, some of the considerations for this, as we've gone around and talked to payers and providers in the country, is, to do this correctly, you have to have really high quality data that's pristine in order to then share it. David, I'll start with you and then go to Patrick. What's been your experience about within an organization access to such high quality data?
Well, I'm smirking, I guess. I'm on the other side of this mountain. 30 years at Jefferson. Half of our system is still not up and running on Epic. Now that we're 14 hospitals and tens of millions, hundreds of millions of dollars, we're still at it. So, kudos to our team, our CMIO, CIO, incredible job. On the other hand, if you look at my chart, if I get a test in another system 5 miles from where I'm sitting, I had to open a second My Chart account. So I won't break, personal health information online, but getting a test in another Epic-enabled system 5 miles from where I'm sitting, I had to have a second My Chart with a second password. And so, we got a long way to go to make this interoperability real. I'm still waiting, and I am 3 months away from Medicare.
Patrick, data quality?
I can't top that pretty much. I am more than 3 months away from Medicare. I've worked with both of you for a long time and learned from both of you. This data issue is critical. So to give tangible examples, Cincinnati Children's at that time, we have pretty much had a catchment of 100% of kids in the area for a number of reasons. So the data quality was actually quite good, but that's not a generalizable example probably. At CMS, I kidded when I started that I had the data, but it wasn't a joke. I had the data I needed for decisions like 2% of the time. We got that higher over time through a lot of work with getting the right data and decisions. But it was, we often didn't have the data and information we needed. And then I think for the healthcare ecosystem, I still practice exactly as described. Within a system, it's getting pretty good, I think. So you can see the x-rays and the data. It's better than when I used to do handwritten notes at Boston Children's down the street with little sticky notes. So that's progress. We're no longer doing that. But now we really got to take that next phase where, it's just the information's got to flow, where if it's 5 miles or 500 miles down the street, that information can flow with the patient and is truly interoperable.
Yeah, and if you look at this picture on the right, this is the new world. So we've had here at Innovator, we've had people come and join our team from Pfizer, which does a fairly good job, as at least most people think, around sharing information across their closed system. And then we've got people joining from Google, from recently Uber, who have experience and knowledge about how do you get to this place where everything's on your phone, right? Where there's that incredible user experience. And that's what this is all supporting, if we truly move forward in this future. But I have to say, I have talked to many payers and many providers in this world, and we've given a webinar around this interoperability rule, and people respond with, huh? What? Oh my God. And you see their eyes get really big. So there's a lot of work to do. Let's take a poll and see what our audience is experiencing. Providers, and particularly with payers, are you prepared for compliance with these new rules? Not only the new ONC rule, but the new CMS rule. Have you already implemented technology policies and processes? Are you getting ready to start implementation and transformation? Are you evaluating different vendors? like Innovator that plan to start, for a fire interoperability platform? You don't think it'll change because you think the government's not really going to do this, or they'll push the deadline out maybe a year or 2 years, or you don't think it applies to this? So this will be interesting to see. Patrick, what's your guess? What do you think we'll find out here?
Well, I hope we're once again higher towards the top. So I'm gonna hope we're higher towards the top. I have to say, on pace of change though, and David Nace, hopefully it's okay to say it. I'm still stuck. So you're years away from Medicare. Just made me laugh. Or months. I'm thinking of several bosses who are like, well, I'm 4 years away from Medicare. I'm sure it'll be interoperable once I'm there. And by the way, that was more than 4 years ago. I'm 20 years away from Medicare. Gosh, we got to go faster. Like, it should be like the interoperable journey has been so much harder and slower than it feels like it should have been. When that's not placing blame anywhere, it's sort of why has the system gone slower. So after we see this poll, I'd be interested in your thoughts. But it just really, David Nace, your example made me reflect back that the pace has not been as quick as it seems like it should have been.
Yeah, I think from a policy person, and I've been the same, I've done a lot of policy stuff in the Hill, it seems quicker because there's been advances in policy, but on the ground, it's been what's going on, maybe someday, not really. I mean, that's been mine. David, has that been your experience as well?
Oh yeah, I'm just looking at the choices, and I think it's going to be number 4. We won't change since the government might push. Yeah, so yeah, I think people are waiting to see, what's the reimbursement situation before they really push on this any further.
Well, let's go ahead and find out what the audience thought. We've got about 560 people on the line, so let's open up the poll and see the answer. Interesting.
Wow, sort of all over the place.
It is. What do we make of this?
Wow. Well,
I'm the optimist.
Yeah, Patrick, you were right. Yeah. Great.
Well, and now we have to execute on it. I mean, I'm glad, for lack of a better description, you got over 50% that are implemented or starting to implement, and another, 20 evaluating vendors. So yeah, I think that's a very positive sign. I think, but you said one of the key things, it's got to be that way on the ground. Like, part of the reason I still practice, and each of us go through the health system in different ways as patients with family members, is, I think we'll know we're there when you just see that reliably for each and every patient person, on the ground, and we're not there yet in terms of interoperability.
No, that makes sense. Well, I think the importance of our discussion today has really been, there's been 2 things going on simultaneously, right? There's been this movement, potentially silver lining movement to virtual care delivery. What might that look like? And then simultaneously, a number of interoperability requirements and reporting and oversight requirements around blocking information and real-time transfer of, no pun intended for ADTs, but of information as appropriate through the continuum of care in a private and secure way for the patient. So what do all these things mean as we go through the uncertain future for the next year? COVID and the getting geared up and getting ready for these interoperability rules. We've already seen a dramatic increase in telehealth and claims. Let's start with you, Patrick. Is this consistent with what you're seeing on the claim side? And how does the payer view this in terms of helping to facilitate the future you have outlined and have always had since you've been at CMS?
Yeah, I mean, I'd say a couple things. We are seeing these kind of dramatic levels of increase, and then the kind of conversations that I'm having at Optum now related to this are, how do we manage, for example, the entire discharge to post-acute to home process? Take risk on that entire process, which we do today, and we will do more of. And we can do that because we build a system around the patient, the people, with the payer. So we say, we're going to provide care. We're going to give them the right set of care. When they're in the home, we're going to have in-person and virtual connections to care for them. we're going to take risk on that, which allows us to invest beyond a fee-for-service payment system. Related to that, by the way, I recently wrote something with Chris Kohler about, one thing I think the pandemic also showed is value-based providers did much better than fee-for-service, not surprisingly. And we should think about our population-based payment systems as they actually support directionally public health and a population health structure. And then we argued you actually could do more. So a future pandemic, you actually mitigate the effects even more as you sort of invest in population health. And I think telehealth's an example where, I think we're going to make real progress that it's not only the right thing to do. In a value-based payment model, you'll deploy these resources that move population health in the right direction.
No, this is really important. And, David, you've been in the thick of it in the Northeast. Just before we got onto this, one of my team members who knows you very well, Adrian White, said to you, maybe this is all Jefferson. Right?
Well, it could very well be, and led by Judd Hollander and Steve Klasko. I mean, Judd's emerged as a national telehealth leader in the ATA, in their journal. I spoke at the ATA meeting just 2 months ago. So again, I think a lot of pent-up demand, a lot of frictionless access, a lot of nervousness and questions and unknown issues, all of it sort of confluence coming together to drive the telehealth agenda. I'm hoping that we're going to get past telehealth and call it, digital health, virtual health, beyond telemedicine. And again, if the marginal cost goes down, broader communities will be engaged, and maybe we could allocate resources more effectively. But I think the take home is it's certainly irrefutable. More cultural change in the last 4 months than in the past, decade, as it relates to accessing, using, and evaluating this type of technology. I mean, it's been an incredible rocket booster for digital health.
No, it's an awesome comment. But Patrick, we're seeing it across the country.
Yeah, I mean, I totally agree with everything David said. Won't say it. More progress in the last 4 months across the country. I don't think you'll reset the baseline. And I agree with the comment. We should think about it not just as a telehealth solution. It's a care system, including virtual care, of which telehealth is a component.
Yeah, I want to go back though, David Dace. Patrick said something that really we have to emphasize, and that is the providers who were on the road to risk fared far better. And boy, that's a take-home message. You and I have chatted about it. We've written about it. I think the marketplace reflected these strategic realities. And let's sort of get right to it. Folks who were getting a per member per month fee to keep people healthy survived so much better than the pernicious do more, see more, test more world. I mean, look, what's it going to take to finally put the knife into the private practice fee for service? I believe it's COVID-19.
No, that's very optimistic, and I really, really appreciate the optimism. I am as well. It sounds like Patrick as well. One of the questions that just came up that kind of relates to this is that, Patrick, you brought up about the issue of hospital mergers. We've all experienced that for many years. What do you think it'll take to really move from a hospital merger that doesn't have the impact on cost and quality to ones that do, given all these changes we're going through right now, as well as this potential Amazon moment? We've had other thinking we've had potential Amazon moments in the past.
Right.
So what do you think it'll take to really get to the moment when individuals at home will get more attention in prevention, and prevention becomes a key component of care, including virtual?
I'm going to answer that question for Patrick. Okay, is that all right? Yeah, sorry, because I'm 3 months from Medicare. I have a certain amount of. It's. I think if you pay us as providers to go upstream and shut the faucet instead of mopping up the floor, that's what we're going to do. And we have 20 years of health services research that would fill the building that I'm in with no other people. that if you pay doctors in a certain way, they're going to change their clinical decision making. And the research evidence, I think, is, at this point, we can't argue. So the provider mergers where there is a health plan involved or a large population doing value-based payment, they're going to succeed.
Yeah,
so that's the answer to the NACE question, I think.
That's a better answer than I could have given. I totally agree. You gotta, it's what I've worked my career on. How do you switch the incentives and go much further upstream? And then there's like markers for this, right? I joke, but it's not a joke. I'll know I'm in the right direction. I did medical school in the Texas Medical Center and residency in Boston. There keep being buildings going up. I literally, in the city that David's in, not at his institution, I gave a speech and was like, what I'm worried about? I think that building that I see going up is probably $1 billion, and that isn't good. So, how do we invest in health and health of populations and getting care into the home? I'll know we're really in the right direction where that's the norm. And look, we have lots of positive examples where that's happening. So now it's, how do you shift the macro incentives so that becomes the norm? And I think we're on a positive trajectory there. I won't quote all the value-based numbers. I'll quote one set of value-based numbers to you. When I started at CMMI, Medicare literally had 0% of its dollars in alternative payment models.
Right. Now it's
then greater than 30%, including still including a lot of one-sided risk. Now we're pushing to two-sided risk and higher, sort of 3B and 4, so two-sided risk models. The trajectory is good. And private payers, we said in North Carolina, it's the same here at Optum, we will pay for better outcomes. Fee for service is not where we're going. And so I think the more that shift happens, sorry, a little longer answer than I meant, I think that's where you'll see the change. And I'll be quiet now. I said I'd be short. That was a little longer than I meant.
So we have this temporary alleviation of rules, and we see this boom in the use of not just telehealth, but virtual care technologies. But there's always been a barrier to it in the past. And actually, I'm getting a lot of questions coming in from the audience about, we implemented a technology for this, it's not working, it doesn't fit in with our workflow. We have another one that said, around the interoperability issue, we just implemented a technology and we're getting crap. We just got a data dump, we don't know how to sort through it. What are some of the barriers in the past to getting to virtual care?
Well, barriers, it's a long list for sure. And again, I'm not a telehealth expert, but clearly I've learned from all the experts who are here, Judd, Hollander, among them. If it's an add-on, we're not going to do it. It's got to be part of, our daily work with a low barrier to entry. I think we're still viewing it as a nice to have, gets people back so we could kickstart the utilization engine. If we view it that way, then it's not a part of the solution. It's still a part of the problem. So I want to go back to where we were, the three of us, half an hour ago. It's got to have a population health component to it, and population health measures, and understanding those pesky social determinants. It's no different than a new drug, a new procedure. It has to look at all of those issues in order to make it a successful part of where we've got to go. Otherwise, it's just an add-on to an incredibly complicated machine that is barely working.
And I just got a question right spot in the midst of this for Patrick. So understanding that value-based payment is the answer, but right now, will the payers continue to reimburse virtual business in the business that is fee for service?
Yeah, I think that'll, as you'd imagine, it's going to vary both in the macro and the detail by payer, but I think you're going to see a general shift to payers reimbursing more for virtual visits, including, in fee-for-service constructs when needed. I think most payers, I cited Rahul, and I've said the same thing. I think most payers are going to generally try to focus on how you put it in a population-based payment model, though. It makes more sense to the payer than one-off. If you have to, you'll pay for, some of these things in a non-value-based way, but your goal is to pay for them in a value-based way. I agree on the barriers. One thing I just want to, I meant to say this earlier and I didn't, so we'll make this point briefly. in mental and behavioral health care delivery, we are seeing, and I'm seeing people write about this, that not only is the uptake greater, the outcomes are looking as good or better. And there's a huge patient preference sort of access issue that I think we're trending in the right direction, which I think is really, we got to keep pushing, but I think that's very exciting. How could we deliver mental and behavioral health care, including substance use treatment, depression, et cetera, and really do that, you know, directly into people's homes through virtual platforms? I think this is a really exciting area.
Well, thanks for bringing that up. We omitted that, and great that you put that on the table. I do, and especially given where the, you know, Maureen Dowd had a great column in the Wall Street Journal, you know, maximum level of national worry and anxiety. God, is she right? And, you know, we see it every day. I know our own family, everybody's family. My millennial children taught me you can't say you're okay. You have to say you're COVID okay, right? If you say, how you doing? I'm okay. Oh, no, I'm COVID okay, which is, you know, millennial speak for I'm anxious, I can't get a job, I'm aggravated, but I'm not sick. So to your point, Patrick, kudos. I think the mental health, behavioral health, we always forget about that. That's front and center.
Yeah, absolutely. So, you know, we talk about virtual care, it's more than just telehealth, right? I've experienced with this for 20 years of trying to put remote monitoring, real-time access to waveform data around wearables so that you can learn more. I mean, hypertension, right? It's one time and place in a year by someone who, in my experience, in the front end of the provider office, is a person who drops that blood pressure way too far and gets an inaccurate reading. Good docs, they'll do it themselves, just to check. So, but blood pressure changes throughout the time, and they may be subsets of different diseases. And I could say that about any disease.
Sure.
So virtual care is much bigger. David?
Yeah, well, I think you are sort of describing the possible Amazon moment right now with Teladoc and Livongo. You know, 10,000 doctors asking folks and looking at their, you know, let's say, you know, thousands of patients with type 1 and type 2 diabetes being monitored all the time. Amazing. Now, you know, it sure sounds cool. And maybe it's an inflection point. Maybe it's a Malcolm Gladwell tipping point. Maybe it's an Amazon moment. And maybe it's all of that. We'll see. I'm excited about it. And I don't think it's a new normal. I think it's just it's the next wave of how we're going to be working. And there's nothing normal about it, for sure.
So Patrick, you're now in the thick of it. You've got this continuum of care, right? Everything from home health and behavioral health to, you know, just post-discharge, acute rehab. Like, how are you thinking about tying all this together in interoperability rules and having the flow rather than having silos of services?
Yeah, so what we are trying to do is to deliver on every physical, mental, and social need for every American when and how they need it, including in their home, which is a big goal.
You know, I didn't hear it, but I've known David 30 years. I just heard him saying, wow.
Yeah, but, you know, I think what's exciting is, you know, I think we have the component pieces, both directly and through partnerships and other mechanisms to do that. And that's what the population needs. So, I mean, you know, this is an exciting time. You know, I often get asked by people about my career, did you plan it all out? The answer is no. But I am very, you know, obviously this is a horrible set of world events, but if there's a silver lining, I do think it's this opportunity to push the virtual care delivery agenda much faster to where it needs to be. When I was at Cincinnati Children's, we talked about 80% of the care should be outside our walls. I still think that is probably about right, but it's like now I think we're at a point in time where we can start delivering on that goal, if you will. And I think at Optum, that's what we're working on, is delivering on that goal: physical, mental, social, across the care continuum, when and where and how patients want it.
Awesome.
Yeah, David, that's probably very refreshing to hear.
Yeah, I mean, it sounds fantastic. Well, let's put it this way, Patrick. You have enough doctors to do that now.
Yes, we do. So no, I mean, we're working through various relationships, over 50,000 doctors, close to 100,000 nurses. I mean, it's a large clinical enterprise. And I think the excitement, though, is what you can deliver in terms of better health, better experience and lower cost. And I think, both, and we don't, we certainly work with United Healthcare, but we work with payers and providers across the country. So it's not just us. It's how do you do it with a broader set of actors.
Sure.
And you're bringing up a great point. In order for this to all get pulled together, we really need collaboration between providers and payers. And there's a lot of questions here, but I'm going to actually bring one up from the audience that just came through for Patrick. I'm just going to read it. As a board member at a safety net hospital with a vulnerable patient population, the desire to do population health in a value-based system is awesome. It's great. But payer participation has been a challenge. Without a strong percentage of payer contracts, and Patrick, you and I have talked about this as the slice of the pie problem, right? The providers, they need to get the majority of payers to really align. Hospitals can't build infrastructure for value-based care, telehealth, and virtual. So, do you have thoughts about this?
Yeah, I mean, I think there is. I think providers, to make this shift, need the majority of their payments, their contracts, their people in value-based models. To do that, you need willing payers. I said this to other groups, part of the reason I went to the payer side is you had more control over the money flow and therefore I think more ability to drive change. It's really hard if you're in a hospital system, for example, with a big blue payer, as an example, that doesn't want to do value-based contracting and they're 80% of your patient population, that's a hard box to get out of. So, I've practiced in a lot of safety net institutions, so this is a real issue. What I'd say is, and I say this to my payer colleagues, including the blue system, like we have an obligation to shift to these kind of payments. And on the flip side, to providers, I had a provider CEO who said, no, I like fee for service. I think I'm going to stick right where I am when I was in North Carolina. And I looked the person in the eye and I said, that's fine. You're no longer part of my network, like, period. So go think about that and tell me whether you want to come back. And they came back a week or two later. And granted, North Carolina had 65% market share. So, that matters in life. But both on the payer and provider side, we have to go on this journey together, which gets on the collaboration. And you need both sides of the equation.
Now, every market's different. And, my last 20 years working across this country with payers and providers, one of the things I've noticed is some markets are single payer dominant, like the Philadelphia market, David. I'll get to that in a second. Others might have, a provider, a hospital health system dominance with a bunch of scattered payers. And then there's other models too, where you have like two major payers or just a bunch of potpourri of payers, and the same thing for providers. David, you're in a unique market. Every market is unique from that perspective. I want to give your perspective.
Well, I'm not going to name names, but we're in a big blue market, and they have a plus-minus relationship with value-based payment. This is not a new situation. So what I would add to Patrick's excellent answer, it might take a new payer coming to a market as a disruptor to push the value-based payment agenda. And I think you're going to see that more and more. And it certainly could be an Optum, gigantic national, but it doesn't have to be. I think in lots of markets, a new payer comes to town, is willing to take risk, in multiple ways, and is willing to sign up providers who want to be on that journey with them. But to Patrick's other comment, if you could be in a big box and not get out if the major payer is not willing to do this. Why they're still stuck in that form, it's hard for me to understand. I think they have, mural dyslexia. They can't read the writing on the wall. But, good Lord, what's it going to take? David Nace, you and I have chatted a little bit about this. So here we are in the middle of August, right? Raise your hand if you think that the system that brought us to the edge of the abyss, to the worst record in the world, to 1,500 deaths per day, you think this is the system that's going to take us successfully into the future, God help us.
Well, I'm
That's
hopeful.
the reality.
I'm hopeful, like both of you are, that this interoperability rule, this idea of data sharing, the need for pristine data, having collaboration across continuum care is all going to be one of the answers. And payer-provider collaboration. The way we think about this at Innovator, and I know I've talked with both of you about this extensively over the years, that if you bring in data from all these sources, which is including the community-based organizations who address the social determinants of health, and they haven't historically been included, we're now seeing these models evolve. In fact, we're supporting them here at Innovator, the accountable communities of health model, for example, and bringing all that data in and ensuring the quality of that data. And then activating that data, and this is what the interoperability rules were all about, activating insights into the workflow of the tools people are using. So, as someone's in their EMR, not asking them to rip and replace, but giving them insights the way your Waze in your smartphone will give you an insight when you're looking at the dashboard of your car. A better example might be the airline industry, because there's multiple people in the ecosystem. It's care coordination for particularly chronic care, having the individual, this is key, personalized engagement with their smartphone, with all of these team members. They can all, the term we use is care as one. David, I know you get excited about this vision.
Well, I just love this slide. I think it's a great picture that really sums up a lot of what Patrick and I were talking about, with the patient at the middle, the care coordination, the data, the command center. I just think it all sort of makes sense. And being a member of the Innovator Advisory Board, if people ask me, why did I sign up? This is why.
And Patrick, you now have this continuum of care where you're really facing silos that have been historic. Behavioral health is implementing telehealth, but they have no connection at all with the rest of the medical continuum. We didn't even get to things like dentistry or the pharmacist, right? So how are you viewing how technology can support you, particularly in the view of the framework here?
Yeah, I think, I'll be brief. I think the concept captured in this slide is right on the whole system surrounded by the patient. I think we too are thinking about all the system aspects, including how you integrate mental and behavioral health, the social aspects of care, remote monitoring, a whole AI and data and technology. So no, I think the concept here is right on and really builds from the conversation we've had today.
Yeah, we haven't even talked about, one of the folks that brought this up is, we haven't even talked about the issue of the opiate crisis, right? So there are multiple things that are all coming to head, and even a couple questions about that, about oral health, which has always been somewhat separate. Patrick, I know you as a pediatrician, and oral health has been critical, and generally, dentistry has been kept out of the model. So lots of stuff, and again, not even getting into the community-based organizations engaging and addressing very specific social determinants of health. But so lots to talk about in future webinars. I just want to open it up. I've been addressing questions as they came along, and I think we've tackled most of them. I just want to open up if you have any closing comments, and start with you, David, and then Patrick.
Well, yeah. First of all, great to be together again. I really appreciate the opportunity, and I'm hoping that we could reach populations with this new technology who we haven't been able to reach in the past. That would be a great outcome from our perspective here at the nation's first College of Population Health.
Patrick?
Yeah, I think we've talked today about better health outcomes, exceptional experience, lower costs for populations of patients. And I think this push to deliver that when and how patients want it with a virtual care system, integrating mental and behavioral health, and using the data and the information as a tool to drive change and learn faster, I think is right on target. So thanks for having me.
Awesome. Well, we'll make this slide presentation available to the audience. A couple of references that were made. I see my team was busy looking them up. David, you made a reference to an article, and Patrick, you did too, when you did with Chris Kohler. Our team will get that out to the rest of the audience as well. I just really want to thank both of you for participating in this. It's been great. Really appreciate it. David, Patrick, thank you so much.
Thanks again.
Appreciate it.
Thanks, Patrick. Thanks, David. And thank you, audience, for attending today. This concludes the webinar.